The single biggest problem in communication is the illusion that it has taken place. And that famous phrase is attributed to George Bernard Shaw, and it may be apocryphal, but I think any patient who's wended their way through the US healthcare system relates to that phrase, that what they say, they don't think their doctors actually hear. I once had the chance to interview a physician who told me about a very challenging patient of hers, a young woman with very difficult to place symptoms, something immunologic, rheumatologic, connective tissue, not clear, but the patient wanted these ever-aggressive experimental treatments. And the doctor was really concerned about the toxicity of these treatments. And the doctor said to me, this patient wanted me to be her partner in these toxic, dangerous treatments for diagnoses that weren't proven. And then I had a chance to speak with the patient separately, and the patient saw it quite differently. She said, my life was at stake. I needed her to push the envelope, and her hesitation was costing me time. And it wasn't as though one person was right or one person was wrong. They were both intelligent, thoughtful women. They respected each other. They were both self-critical, took responsibility for their own shortcomings. And nevertheless, they saw it so differently. And I think about when you see a movie and the scene is filmed from two different cameras, how different it looks from these different cameras. But honestly, at times it felt like they were in two different movies altogether. The patient said it was like being in a rowboat, each rowing in the opposite direction. And so their experience is what drove me to write a book called What Patients Say and What Doctors Hear, and of course, vice versa. Because the gap is huge, and in that gap is the potential for medical error, misdiagnosis, mistreatment, and of course, poor use of healthcare dollars. And we tend to think of communications like bedside manner. It's an affable bonus that some kindly doctors, usually of the bow-tied variety, possess. But it's good if you can get it, but you always hear about, so-and-so is this phenomenal doctor, not a great bedside manner, but they're still great. And what I learned from talking to patients and nurses and doctors and researchers is that those are mutually exclusive. You can't be a good doctor or nurse or physical therapist if your communication skills aren't sharp. It just doesn't work because the medical care can't be delivered well. The Greek philosopher Epictetus said, we have 2 ears and 1 mouth so that we can listen twice as much as we speak. And it's clear that Epictetus was not a physician in 21st century America. Or as any patient can tell you, and the studies bear this out, that doctors talk much more than they listen. And we verbally dominate the encounter, and especially so when it comes to minorities, women, elderly, disabled, and people with psychiatric disorders. We even more take over the situation. And you know the data that doctors cut patients off in 8 seconds, 10 seconds from opening their mouth. And when I talk about this with lay audiences, they're horrified at that data, how rude those doctors are. And I try to explain that we're not trying to be rude, at least some of us, but that we have this dogged detective instinct. When the patient says, I have this pain here, we jump right in. Oh, when did it start? How long did you have it? What makes it better? What makes it worse, right? We want to get to that diagnosis quickly and efficiently and accurately. But of course, if the patient had a second thing to say, like, I think I might have had a stroke last week, we never get to that. And so you can see the potential for misdiagnosis, for errors in treatment and care, and misallocation of dollars. And so I often wondered, well, how long would a patient talk if we just let them go without saying a thing? And I asked my colleagues, they were horrified, oh my God, don't ever do that, you'll never finish, not the Puerto Ricans, not the Italians, don't let them talk, God, we'll never be out of here. So I looked and I found one study from Switzerland which did exactly that. They let the patients talk, they clicked on a stopwatch, didn't say a word. How long did they talk? On average, 92 seconds. Right, not the tsunami that we were all fearing, but the Swiss, reserved, precise, diplomatic, maybe they don't have the American gene for loquacious gab. Okay, I'm trying this in my clinic. So the very next morning at Bellevue, I did the same experiment. So the first patient comes in here for checkup, 38 seconds, but pretty healthy. Next patient, a little back pain, some weekend warrior shoulder pain, 41 seconds. My God, this is pretty good. Next patient, middle-aged guy with a cholesterol, glucose, waistline all edging up, 52 seconds. I'm like, this is it. This is really great. Let the patients talk. They'll all stop, in a few seconds. But then came the kicker. Josefina Garza, not her real name. Miss Garza is a teacher in her native Argentina. And she's saddled with a vast array of insoluble aches and pains. She's got irritable bowel syndrome, anxiety, depression. She's got an elderly, cranky mother to care for, a good-for-nothing son who hasn't gotten a job and moved out, an unsympathetic boss who makes her life miserable. And, she's had the $1 million workup. It's all been negative. But if I let Ms. Garza speak, without cutting her off, we would be there forever. I get a rundown of symptoms from every single organ system of her body. I get the whole rundown of her mother's, medical issues and what their doctors were doing. I'd probably get a stinging critique of the Metropolitan Opera's soulless production of Turandot. And, we'd be there forever. I wouldn't have any explanation for, her aches and pains. I'd be forced into trying to justify what her mother's doctors are doing. I'd be defending the artistic director at the Met, who, routinely desiccates Puccini. The whole thing would turn out to, we'd all be in a sour mood. It would turn to be a sprawling, onerous mess, kind of like an atonal Schoenberg opera, which she would excoriate on philosophical grounds. But I promised myself I'd let all my patients speak uninterrupted. And if I eliminated my, difficult patients, then my data, however informal, would be flawed. So I girded myself for battle. I said, how can I help you today, Miss Garza? And reluctantly clicked on the stopwatch. Every single thing hurts, she said, from my nose to my toes. There are shooting pains in her gums and throbbing veins in her elbows. Her mother was up all hours of the night needing the bathroom and having various aches and pains. Her good-for-nothing son was still playing video games in the basement. And each time she paused, I said, anything else? And there always was. I'm only 45, but I feel like I'm 85. My head's swollen to 10 times its size. It's like I'm walking through molasses. And on it went. And I thought, oh boy, we are never gonna get done. 20 minutes after our 15-minute visit finished, Miss Garza finally came to the end of all she had to say. But when I peeked at the stopwatch, 4 minutes and 10 seconds. And the Met came out unscathed. And it was really an amazing revelation. Though it felt long, it actually wasn't that long. And then when we were done, we had a list. It was long, no doubt, but it was finite. It didn't go on forever. And once we had the list, we could work on a plan. Okay, we'll do these few today, we'll do the next dozen next time, and which of these could we help with physical therapy? Where with a social worker help out with your mother? And then she said something that I'd read about, but I never legitimately heard a patient actually say. She said, just talking about it has made me feel better. I wanted to get up and sing an aria, but luckily for all parties involved, I refrained. But I realized, that for patients like Miss Garza, we dread these patients, right? They're the ones who are always doctor shopping, who way overutilize care, the ones of the 5% who use up 40% of the dollars. They get all the excess treatment, overdiagnosis. They get all the, side effects of poor treatment. They get the medical errors. And they really stress our system. And so I think for patients like Miss Garza, they're used to having walls erected around them. And for one time to not have those walls, it made a difference. And whether her cortisol was lowered or just she felt more comfortable, she felt better. And that is the name of the game and what we do to make our patients feel better. But I realized something else, that I was feeling better. Because with patients like this, I feel like I'm just rearranging the deck chairs. And this is the first time I felt like I'd actually done something. And thereafter, our visits were much more efficient and much smoother. It was really money in the bank. And so when I talk to my students and residents about being efficient in medicine, and we have a very busy primary care clinic at Bellevue, I talk to them about the counterintuitive strategy of letting the patients talk uninterrupted. Because most patients will get at what they have to say in that first minute. And if you give them 1 minute of what we call kind of full frontal listening, eyes focused on the patient, no computers, really listening, without thinking about your pager or when the minestrone soup will run out at lunchtime, you will really get what you need to hear. And then the patients aren't going to be bombarding you with last-minute, hand on the doorknob questions or 3 emails or phone calls later. And you'll see that it really invests in, in the patient's future. And, Ernest Hemingway said, when people speak, listen completely. It works for novelists. It also works for healthcare providers. And so all of us here, I think we adhere to the tenets of evidence-based medicine, right? We want evidence that supports what we do with our patients. But what about how we speak? Is there evidence that the way we speak or what we say actually changes clinical outcomes? So way back in the age of the dinosaurs, in 1964, someone did a very simple study involving post-op pain for abdominal surgery. And if you've had abdominal surgery, you know what a big problem post-op pain is. And we tend to treat this intractable pain with opiate narcotic medications that, as we have heard, have a host of side effects, from nausea, vomiting, constipation, to addiction, respiratory suppression, and death. So minimizing opiate use is clearly a high priority for all stakeholders. So in these 100 patients going for abdominal surgery, the night before, the anesthetist went to each patient per usual to talk about the surgery the next day. But for half the patients randomly selected, they also got a 20-minute conversation about post-op pain. You know, where the pain usually occurs, when it might come, how it's caused by the clenching of the muscles. Here are some exercises to relax the muscles and relieve the pain. If that doesn't work, here's how to call the nurse, here's what you might get. You know, not rocket science. And then the next day, the surgeons who didn't know who was in what group operated and took care of the patients. Now, from the vantage point of today, it's obvious, right, that the patients who got the education about pain did better. But it was the magnitude that made me sit up and pay attention. Those patients with the extra conversation used half the amount of opiates, right? That's an enormous, meaningful clinical outcome, half the amount of opiate medications. But moreover, those patients were discharged from the hospital 3 days earlier, right? 3 fewer days of nosocomial infections, C. diff, infiltrated IVs, DVTs, PEs, D-cube ulcers, not to mention some $15,000 in today's money, all from a very simple conversation between a caregiver and the patient. So why is it that conversations with patients and caregivers get no respect? Well, if you talk with your patient, right, Medicare will reimburse you, what, $49 on a good day. But if, while you're talking to the patient, you simultaneously thread a tube into an orifice of your patient, and you pick any orifice you want, that reimbursement goes up 10 or 20-fold, right? And if while you're threading that tube in, you run a CAT scanner over them or some imaging modality, you're talking thousands and thousands of dollars. Our system is so weighted toward procedures that if you're a CEO of a hospital or healthcare system, it makes sense to be doing those procedures, not spending time on chit-chatting with your patients, because that's how you stay afloat. But of course, medicine today, as we know, a very small part of medicine is acute, easily solvable problems like surgical resection for appendicitis, right? Medicine today is chronic illness. It's diabetes, CHF, addiction, obesity, congestive heart failure. These are the things that require conversation, education, medication adherence, lifestyle changes to treat and ultimately to prevent these diseases, conversations about big ticket items like whether or not to do chemotherapy, when to start dialysis, what to do about end-of-life care, all mediated by the doctor-patient or the caregiver-patient conversation. And so my take-home message, not just that communication is important, yeah, we all know that, but that the conversation between the patient and their caregiver is the single most powerful tool in medicine, and it overshadows any other tool by itself. I mean, you can practice medicine absent almost anything, but without being able to talk with your patient, it's almost impossible. And so, when we think about what a conversation with a patient can accomplish, the information, the amount and variety that can be extracted from a conversation, the diagnoses that can be made, the analyses that can be elaborated, the treatments that can be rendered, not to mention the human connection that can be formed that is a huge predictor for long-term care. The conversation with the patient is, in fact, a highly sophisticated technology. It's actually quite a bit more powerful, intricate, and flexible than most of our other medical technologies, which, if you think about them, typically only do one thing in only one way. So we talk about innovating in the medical system, about restructuring how we give care. We need to recalibrate the balance to give more attention to what really makes a difference in taking care of patients. If we're thinking about efficiency, cost effectiveness, accuracy, diminishing medical errors, keeping patient safety in the forefront, important clinical outcomes, it's really the conversation between patient and their caregivers that is our most effective tool. And that we need to give it the attention, the deference, and the reimbursement that we lavish upon the swankiest of medical technologies. And the good news about communication, compared to lots of other things we do to our patients, is that it is cheap, right? It costs much less. It also doesn't put you into renal failure or make you puke. It doesn't constipate you or decimate your sex drive or make all your hair fall out. And I wish I could say the same thing about communication from our politicians these days, but that's a whole other story. So thank you so very much.